And then your lupus, you've had that for a long time?
Since I was 21, SLE, systemic lupus erythematosus.
And then remind me, who's your kidney doctor?
Dr. Panda.
Pandy?
Pandy, yes.
Okay. And he's thinking about doing PD on you instead?
Yeah, because it's been dropping like every 3 weeks. It drops 1 point, and it's actually trending down a lot. Yeah. So I've been having kidney problems since I was 22, 23, and I knew someday it'll be getting here. So and I've been having really bad nauseous.
Did they ever your kidneys? Obviously, you probably have some, glomerulosclerosis or nephritis where this gets nephritis. But do they say if the kidneys are large, or do they say it's getting smaller? Do you know if he said anything like that? Okay. And then your skin lesions, typically we'll see that quite often with lupus patients, like lesions and so forth. Have you had a lot of that?
Oh yeah, all through my body.
Yeah. How about in your belly?
It used to be only on my legs, but now it's trailing all the way up.
My hands are really cold. Okay. It doesn't look bad actually.
It's trailing to my arms.
What's and then your scars there? Where is that from?
Spleen neck.
Yeah, they're just spleen removed.
Yeah, it's being removed. Yeah, it was let's give this a try and see if your blood count goes up.
Okay.
And it did go up a little bit.
Do you remember what your last platelets were?
The last one was good. I think it was maybe 110 or something like that.
Not
Yeah,
bad,
but it was a couple months ago. It was 56.
Okay.
Yeah, 56.
And typically, the ones I have here, your last platelet was 78, and this was from October, so it's been a while.
The doctor, he's my hematologist downstairs.
Dr. Khan?
Yes.
Yeah. Sometimes we have to or transfuse you before surgery, or before you go back for surgery, to increase the platelet count.
Yeah.
Usually in the 70s and so forth, I'm not too worried about it, especially if you're like brushing teeth and all that stuff, but you're not bleeding much, or any IV pokes or anything that you're not bleeding from, then that should be okay too. Because the number is not just a number we look at, but also the functional status of the platelets. Okay. As far as PD goes and risk of infection, in general, there's a risk of infection with PD. It doesn't matter who you are. Because you have something sticking out of you. The catheter has tissue around it. We call that a little fibrous or a little cuff that causes a lot of inflammation around it. So that's what kind of seals the inside from the outside. Okay. So that minimizes the risk of infection, but there's always a risk of infection. Now, having add lupus to it, I don't know the percentage to say, your percentage is like 40-50%, because it would not make any sense for us to put this in. But it would be a little bit slightly increased because of previous skin lesions and so forth. But I don't think I would sit here and tell you it's prohibitive, unless when I look at you and you have all these open wounds and so forth, I would say no, it makes no sense, because we know there's a high risk of infection. But just because you have lupus, I don't know if necessarily I would sit here and say don't do it. But once we put the catheter in, typically what I tell most of my patients, the first thing you're going to do is not call me or Pandy, is call your PD nurse, say, hey, my catheter is in, so they could show you how to keep it covered and maintain, and then they'll eventually do flushes and then start using it. Okay. With the surgery entails, usually I'll make a small incision up here and put a camera inside, and then usually where your belly button is, to the side of it, is where the catheter goes in, and it sits in the lower part of your abdomen. And really what this tube is doing is letting you get fluid inside of your belly, and it will exchange the good stuff with the bad stuff, and then you take it back out. Okay, and that's what the catheter does. In regards to the catheter, typically it works well. There's a small percentage, sometimes the tube has little holes that gets clogged up. It may not work well, or where it's located, but usually we'll flush it, get it working to make sure everything looks good before we close everything up. And then obviously the surgery places that we put them in, you've had previous surgery obviously for your splenectomy, so you're going to have some scarring in there. So there's a little slightly increased risk of damaging structures as we go in, liver, bowel, and so forth. Very small risk, but slightly larger than average, but again, not prohibitive. And then the last component of all this stuff is in regards to maintenance. again, you would communicate that with your PD nurse to keep an eye on it and cover it appropriately. They'll show you what to do so we can minimize the risk of infection with the catheter. Okay, surgery usually takes about 10 to 20 minutes. It's done under general anesthesia, and then afterwards, as long as everything goes as planned, you'll go to the recovery and then go home afterwards.
Okay.
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 Does that make sense?
That makes sense. Can I ask you a question?
Please go ahead.
Okay. Can I feel? I mean, like.
What you'll see is a tube sticking out of you.
Oh, okay.
It gets covered, but you do have something outside of you.
Outside of me.
Yeah.
And what else? Would I be? Is it very easy to ruin it by sitting, exercising,
no.
or something?
You do normal stuff.
Normal.
Except they'll go over with you how to shower and bath and all that
to
stuff.
do.
Yeah.
And if, let's say, it clogged up,
Yeah.
then would you just flush it, or would you take it out and put a new one?
Yes and no. So if it gets clogged up or it's not working right, the first thing we'll do is kind of troubleshoot it, like you said, flush it, put some stuff in there, see if it removes anything that might have caused it to clot off. We call that usually fibrous tissue. And then sometimes I'll have to go back in laparoscopically to either reposition it if it's not working right, flush it, or even remove it and put a new one in a different location.
Okay. Would Crohn's disease be a factor? I have a little bit of IBS.
I don't think so, but with Crohn's, obviously, we worry about visualization, the bowel connecting to bowel or to the skin. Typically with the agents that are already out there for Crohn's, we see less of those stuff happening, but there's always a risk of that. But I don't know if necessarily the PD catheter will cause that more likely to happen.
Okay. And what happened if do you do the surgery for the in-house too, or somebody else?
Yeah. So if you decide to do hemodialysis instead of the peritoneal we do at home at night, then you talk to Pandy about that and then let us know, and then we could switch to PD placement to the access placement. Now with the access, you're right-handed or left-handed?
I'm right-handed.
So we would try to put this in your left arm to avoid any issues on your dominant hand. Obviously when we do these, we're taking a vein and connecting it to the artery, and sometimes you could get less blood flow moving to the hand. So some people may have numbness, even weakness, or even paralysis, which is a real small likelihood. But we do this in your non-dominant hand for that reason. And when we put the one in the arm, typically it takes time for it to grow and be ready. So if you need a dialysis, say tomorrow, then we would put a catheter in to get your dialysis, do this, get this ready, and then eventually switch it to the hand.
And that's one more dangerous, right?
I wouldn't say it's more dangerous, but hemodialysis versus peritoneal, that's really where Pandy comes in to see if you're a good candidate for both and which one gives you better options. With hemodialysis, you go 3 times a week. It's 3 times a week, then you get clean. PD, you get it every night, right? Risks, obviously, if you have an access in your arm, whether it's a fistula, which is your own vein, or an artificial one called a graft, slightly increased risk of infection, but not crazy amount to say you can't do it. As opposed to the PD. PD has a risk of infection also. But it depends on the person. Some people don't want to do this at home. Some people don't understand how to use it or feel comfortable. And some people are not good candidates because they may be real brittle diabetics and their sugars go up with the PD dialysis. Some people prefer to go to hemodialysis and not deal with all this stuff. Everyone's different. I don't make that determination.
Okay.
But if you flip from one to the other, it doesn't mean that we can't do it.
Okay.
And more importantly, if you do PD, say today, and then tomorrow you change your mind and you want to do hemo, it's not like you can't do it.
Okay.
Yeah, we can always put the access in the arm and get your PD out. So there's options out there.
Okay, great. What else? The hemo. So I heard that, since mine is dropping so low so fast, the PD is the best one for me because you could do it right away, right?
Yeah, PD you could do it right away, but if you need hemodialysis, we could also put a catheter in and start you on hemodialysis.
But is that more of a risk because it's vascular?
No, I mean there's a risk of infection with catheters. That's why we try to put them in the arms for hemodialysis. But it doesn't mean that you shouldn't get it done because you're going to have a risk of infection.
Okay.
So I don't necessarily say that that's, again, a prohibitive component that you shouldn't do it, but I'm not the one that has made that determination as far as what's better for you. That's with Pandy. But again, if you do, let's say we schedule your PD tomorrow or next month, whatever it is, and you do it, and then you're like, hey, that's not for me, and Pandy agrees, and you could do hemodialysis at that point.
The HD one,
Mm-hmm.
the needle goes into
Yes.
the tube, right?
Yeah, so your fistula, which is your own vein that
Yeah.
gets bigger, or a graft, which is the artificial, they put one needle in to take blood out, put it through the machine, and then the second needle to put it back in, and you would do that usually 3 times a week.
It's not poked, right?
It is poked.
Oh.
Yeah, so at first it's not fun because they're sticking needles in there, but over time the area becomes less sensitive, more insensate, and so so the feeling of the poking becomes less and less noticeable.
Like poking in the skin or poking in the...
No,
you
both.
do poke in the skin.
Yeah, you poke through the skin into the structure, whether it's your vein,
Oh.
fistula, or a graft.
Oh, I thought there was a tube there and then you just go
No,
through
there's
it.
nothing that sticks out of you that like every time they just hook you up to it,
Oh,
they have to poke you twice.
I thought that was,
Yeah.
yeah, I was worried that was the case because then,
No, there's
I
nothing
have-
sticking out of you.
oh man. Because I have very, very small veins.
Well, that's what I'm
Collapse,
saying.
sometimes collapse veins.
But the thing is, we are not having your normal vein being used. We're connecting the vein, if you have good veins, to the artery to let that vein get bigger and get more blood moving through it. That usually becomes less of an issue because we're doing what we're having to do to connect that to get more flow through it. But it depends on whether we could use your vein to create that, if it's big enough. Not so much if it collapses, and also if not, then again put an artificial one in there called a graft.
Oh, artificial one. If they can't do that, they put an artificial one.
Yeah, if your veins are not good, then I will put an artificial one called a graft in there.
Mhm.
So before surgery, typically we'll do an ultrasound of your arm so we could get a sense of what your veins look like. And usually also in the operating room, I'll map your veins with an ultrasound so I could see what veins you have that are good.
Mm-hmm.
Yeah, if the vein, there's 2 veins just to kind of go over that part with you. There's a vein here and one's deeper. If the one that's closer to the skin here is not good, then we would use the inner one, let that grow once it's big enough because it's deep in the arm. We would come back and make a longer incision and elevate it. If that veins are not good, then we would put the artificial graft in there.
Oh, okay.
Yeah. And usually I'll make an incision around the elbow typically, or one here for the graft.
Okay,
Yeah.
got it.
Okay.
Okay. So when do you think this surgery?
Let me have her come and coordinate with you about timing of this. I know with the holidays and everything, it's been kind of a little backed up, so it's probably going to be towards the end of the month, if not early next month. I don't know how fast Pandy wanted you to go on PD, but if he thinks you should get it done now, we could try to also.
I mean,
squeeze you
I've been so stressed. I just want to get it over with. You know what I mean?
Yeah.
I've been so stressed about it, and so let's say I say let's do the PD,
Yeah.
and then like before the surgery, I'm like I want to change it to.
Yeah, just let Victoria, who's going to do your surgery scheduling right now.
Uh-huh.
I've had patients like you, so it's not unusual for us to see that every so often.
Mhm.
You just call her and say, hey, I talked to Pandy or changed my mind. I want to do hemodialysis. So we want to put something in the arm.
Thank you.
Okay.
Thank you.
Your GFR, last time he had you seen, like I said, let's see, when was this note from? This was from 10-1. So I don't know if you've seen him more recently. I imagine you have.
Yes,
probably,
I did.
Right? Because last time your GFR was like 16, 19, 24. Do you remember what he told you on the last
The
one?
last one was 12. I have the labs that I did with him if you want to see it.
That's okay. I put 12, so at least we have a sense.
12, 11. I remember it was 12, 11. It could have dropped more, but I haven't done another lab yet.
But you're not short of breath or nausea, vomiting, like
Nausea.
swelling. You do have nausea?
Nausea.
Okay.
Yeah, it's like, yes, nausea. And I'm very tired.
Okay. Yeah.
Yeah, nausea and very tired.
And those sometimes can be signs of what we call uremia.
And itchy.
It is, yeah.
Very,
those
very itchy.
Those are sometimes signs of what we call uremia, where you're retaining some of this stuff in the blood that's not clearing out.
And
then
headaches.
It gets you itchiness, nausea, weak, that kind of stuff.
I don't know if the headache count, but I've been having headaches.
Yeah,
Tylenol.
I don't know about that one, but Well, let me have her come and schedule you. I put
Perfect.
on there to get you scheduled in the next 2 to 4 weeks, so we'll
Okay.
kind of get this along. We'll schedule you for laparoscopic PD cath insertion.
Okay.
If you change your mind, obviously let her know. If you change your mind after the surgery, like, you know, a couple of weeks into you doing this stuff, you're like, I don't want this, we can always
That's
schedule
awesome. That makes
Or,
you
you know.
very comfortable. Makes me calm a little bit.
you. Yeah, so what I tell most of my patients, it's not like you get one that's it type
That's
thing.
it. You're
This is
good.
it for
You're
life.
wasting my time.
Yeah. No, I mean, you know, it's usually patients, and I've had patients for 3-6 months have had, you know, PD, and they're like, yeah, I don't think this is for me.
Yeah.
And then they change their mind to get hemodialysis done at that point.
Thank you,
Yeah.
Doc. I appreciate it. Thank you for letting me record it.
Yeah, absolutely. She'll come in here and coordinate with you right now, and then we'll go from there.
Thank you.
Okay? It's nice meeting you.
Nice meeting you.